This conference will now be recorded.
Hello again, and let's guys discuss some questions in the diabetes in pregnancy and see how easy is the questions and are we really understanding the topic very well or not. So the best way to find out is simply that you guys check by a mock test. Okay, this is what we advise. Our quiz today is very simple. Okay, it's from the common questions. Some of them appeared recently. Okay, and it's available free on our website under the free mock test section. Okay, this is self-enrollment course, so you can just register and enroll yourself, and that's it. Okay, so this is the diabetes in the pregnancy, and let's see how is the quiz starting now. Number one question is single best answer question. This is a mixed one, okay? So we will find EMQs and we will find single best answer question. Let's read together and see how are we doing. So we say for the question number one, you see a primey at 37 weeks of gestation with type 1 diabetes. She has been diagnosed as having a pre-proliferative diabetic retinopathy at her routine screening during pregnancy. The estimated fetal weight is 3.56, and she's booked for induction of labor at 38. Okay, and at 38 of gestation. What is the most appropriate advice for her labor and delivery? So you guys, what do you think? Hopefully that every one of you can see the screen already. Otherwise,
Option D.
okay, so would you please repeat your answer? I couldn't hear you very well. Hello?
Aim of vaginal delivery with no limitation on the second stage. As
Yes, well done. Yes,
estimated
and
fetal weight is 3.56. So it is the average fetal weight.
okay, so the average fetal weight is 3.56. Okay, and what the tricky point here that can make the candidate actually be confused in this question, that that's a pre-proliferative retinopathy, right? Because for the patient with a proliferative retinopathy, already retinopathy is done. So for such patient, what we will advise, we will advise limitation or short the second stage and elective use of instrumental delivery. However, in a pre-proliferative, there is no need to do any limitation for the second stage. So the answer is D. Yes, correct. Thank you very much. Next question says, babies who are born to mothers with diabetes during pregnancy require extra care to avoid and manage the risk of neonatal hypoglycemia. When should the baby first fed and its blood glucose level be checked? What do you think, guys? We will advise that the woman had a breastfeeding or start feed her baby as soon as possible or within 30 minutes of birth, right? So when to check the blood glucose? 2 to 4 hours from the
2
birth
to
time.
4 hours.
Yes, so would you please guys remind me, what is the level of the blood glucose in the neonate? It should be at least what? I'll give you choices: 2, 5, 4. Yes, it's 2. Excellent. Well done. It should be at least 2, not less than 2. Okay. Okay. So here is the question about 41-year-old Primey with gestational diabetes under diet control is induced at term. She's 5 cm dilated and on oxygen infusion. How should her glycemic control be monitored and managed during labor? Select the most appropriate option. Okay, so what is the most appropriate option, my dear friends? So I can see here that
Option
Dr. Iman and who else choose D? So Dr. Iman, you are choosing D, and D is at 1 hour, okay? Frequency of capillary blood glucose monitoring, this is 1 hour. Start the sliding scale at 4, okay, to 7, right? So option D is the correct one. Yes, well done. A 35-year-old gravida 2 para 1 at 36 weeks of gestation with gestational diabetes has an appointment in your diabetic antenatal clinic to discuss mode of delivery. What aspect of additional clinical history would warrant an elective cesarean section? What would make you schedule the lady for elective cesarean section? A diabetic lady. Options, as you can see, number 1 is previous normal vaginal delivery of 4.6, which is a good thing, right? Gestational diabetes requiring insulin, poorly controlled, and the expected fetal weight is 4.4, or previous cesarean for breech, or breech presentation and willing to attempt ECV, or gestational diabetes requiring diet control alone, good control, estimated fetal weight of 5.1 at 39 weeks of gestation. So I can see here, okay, my dear friends who wants to suggest cesarean section for gestational diabetes, poorly controlled, but the estimated fetal weight is 4.4. No, dear, 4.4 is not actually a contraindication to attempt vaginal delivery. So B is not correct. Okay, Dr. Parrell here, she chose C. C, my dear, previous cesarean section for breech delivery. You know what is the chances of success of a VBAC trial after cesarean section of breech? This is from 85%, okay? 85, this is very high, okay? So this is a very high success or chances of success, so it's not the answer. The answer here is E, as many of you already answered. Well done, okay? Why? Because the estimated fetal weight is 5.1. So we will say for GDM, okay, a patient can attempt a normal vaginal delivery up to 5 kg of the baby. For type 1 diabetes, okay, type 1 is, what is this estimated fetal weight when we can consider cesarean section for her? I'm not saying must or offer, I just say consider the cesarean section for this patient. If you have, for example, a previous problem or a complicated delivery plus one factor, you know what is the factor? It's 4.5. And why did we, you know, use, okay, the 4.5 in the diabetic patient? Okay, that's because simply the problem with the baby who's growing large and the mother is diabetic is this is a distribution of fat. Okay, so they have more of truncal obesity. They have more chances of shoulder dystocia. Okay, so this is the situation. We have a question about Mrs. Kausar, who is diagnosed with type 2 diabetes 3 years ago. She's currently on metformin 500 mg 3 times per day, and her glycemic control has been good throughout the pregnancy. Her recent growth scan at 32 weeks of gestation showed that the fetus is growing along the 50 centile, 50. She is currently 35 weeks of pregnancy and admitted to the delivery suite with clear fluid as per the vagina and tightening. So the lady had a premature rupture of membrane. Examination confirmed cephalic presentation, premature rupture membrane, and she is 4 cm dilated now and absent for water. The admission, CTG is normal. Her capillary plasma glucose at admission is 7.6. What is the most appropriate capillary plasma glucose monitoring frequency and level? So this is very similar to one exam question came before, asking about the maintenance of the blood glucose level during delivery, right? And the frequency of testing, right? So frequency of testing means every hour during labor and to keep it between 4 to 7. Excellent. So the answer is monitor every 1 hour during labor and birth and maintain between 4 and 7. Okay, so if I change it, my dear friend, the answer and says, the question and says that she is admitted for elective surgery under general anesthesia. So what will be the frequency of the blood glucose monitoring during anesthesia? Every 1 hour or every half an hour? Yesterday in our discussion, we have commented on this point. Do you remember? Yes, so under general anesthesia, we advise that the blood sugar is tested every 30 minutes and to keep it also in the same range, 4 to 7, right? And if the procedure is prolonged, so the sliding scale is mandatory. Okay, guys? Insulin infusion and sliding scale in the same time. Okay, well done so far, guys. So this question number 6 says, gestational diabetes is common complication of pregnancy. What hormonal factor predominantly responsible of it? This is a very famous part 1 question. Is it the cortisol, estradiol, human placental lactogen, or progesterone, or HCG? Yes, of course, it's the human placental lactogen. Well done, my friends. Yes, correct answer is C. The question number 7 says, you have been asked to review a postnatal woman with a known type 1 insulin-dependent diabetes, who was successfully delivered overnight. She's now eating and drinking normally, and the post-delivery capillary blood glucose reading are all between 4 and 7, so that's good. The plan is to stop intravenous insulin dextrose sliding scale and recommend subcutaneous insulin. She wishes to breastfeed her baby. What is the most appropriate advice for the woman regarding recommending her subcutaneous insulin? So, for a pregnant lady, right, when we advise her to take insulin, we know that most likely during the pregnancy, because pregnancy is a state of hyperglycemia, okay, that the need or the requirement of insulin will increase during pregnancy, right? Once the lady delivered, So we assume that we need to return back to her pre-pregnancy level, right? But if the lady is breastfeed mother, does it make a difference? Do you think that breastfeeding mothers, she need more energy than the general population? Yes, of course. So the breastfeeding even, okay, will reduce her requirement of insulin. Why? Because she will need more energy, right? So the correct answer is to reduce her pre-pregnancy insulin dose by 25%, okay? So once after delivery, once the woman who is type 1 diabetes delivered and she's okay, she can eat, we will stop the sliding scale, right? As a guidance, it's a general guidance, okay, that we will start by the subcutaneous insulin, which recommended a 25% lower dose of the pre-pregnancy, okay, if she is breastfeeding, okay, not all the women, okay. So please take care. The 25% is because of the reduction, is because of the breastfeeding. What is the source of this piece of information? This information comes actually or mentioned in the textbook of maternal medicine, handbook of maternal medicine of Dr. Catherine Nelson Piercy. Okay, and if you know Dr. Catherine, okay, this is the major, contributor of the maternal medicine in the college. Okay, so this book is very useful for your practice, my friends. And here we have one EMQ. Okay, so let's see this EMQ. So the EMQ says the instruction, usual instruction, the following baby is born to a woman who had either pre-existing diabetes or gestational diabetes. For each baby, choose the above option list. From the above option list, the single most appropriate action that you will take in the management of the baby. So please take care. Leading word in the scenario, and this is what we advise all our champions, that you need to read what is requested from you, what is the task, okay, of the question. The task here is to choose most appropriate action, okay. Okay, so what is the story? The story is the midwife on the postnatal unit has reported that a newborn baby of a mother who is type 1 diabetes is feeding poorly and tend to have frequent episodes when he gets blue cyanosis. These are commonly associated with breastfeeding. The pediatrician has examined the baby and noted the presence of a heart murmur. So what do you think is the single most appropriate action? Would you check blood test for the baby? Or will you give intravenous fluid? Or you admit into the neonatal unit? Or echocardiography? Or admit into neonatal unit and organize an echocardiography? So if you are preparing to the part 2 MRCOG, so you will be familiar with the RCOG way, right? What is the RCOG way of thinking? I'll tell you, my friends. The RCOG way of thinking, okay, that they give you 2 or 3 correct answers or similar answers in the EMQ, and you have to do the elimination method, okay? So you have to eliminate the nearest to the true and then compare between each other. Go back to the task required, okay, and you will understand which one to choose, okay? Okay. Appropriate management of the baby, that will be admit to the neonatal unit or echocardiography, or admit to the neonatal unit and organize an echocardiography. Which one? Which one you would choose and why? Okay, so what is your job in this exam? You are a registrar, right? Okay, so you have asked or you have made a referral to the pediatrician, right? And it seems like the baby is with the mother, right? Pediatrician came already and examined the baby. The episodes when the baby gets blue, okay, is associated with the breastfeeding, right? So at the moment, you need one single most appropriate action to do. Are you going to admit the baby in the neonatal unit, or you will arrange for echocardiography to know if the baby has problems or not? Is the baby severely unwell at the moment? What do you think, guys? Severely unwell? No, not severely unwell. Look, my dear friends, the baby will require, okay, the baby will require an echocardiogram according to the guideline, right? Is that correct? Okay. This is the single most appropriate action. Admission, okay, in a neonatal unit or in a neonatal ICU, this will be after that. If the baby is now severely unwell, the baby will be moved to the neonatal ICU immediately. But it seems like your baby is just turning blue, okay? This can be a problem, or maybe the problem is not that severe. How many babies actually you have met in your life, okay, with this problem, and they just went home and they had a follow-up appointment with a pediatrician? And how many of them are severe and require immediate operation? Guys, the single most appropriate action is single action, so it's echo, okay? We don't have here an emergency, okay, to put the baby in a neonatal ICU and take the bed, okay, unless you have some diagnosis or some urgent need for the immediate admission to the NICU. Is that correct? Is that clear, my friends? So taking the decision, okay, is not like as a prophylaxis that I will just go and I will admit the baby in the neonatal ICU, okay, while the baby is with the mother. The baby had the problem while breastfeeding. This can be a sign of cardiac problem, right? But also there is some benign conditions like this, okay, and so many of these babies after appropriate investigation will be just followed up, okay? So it's according, my dear friends, to the severity of the condition. So you need now an appropriate investigation to find out what is the problem with the breastfeeding. The guideline advise echo to be done, right? There is no clear indication in this case to admit the baby in the neonatal ICU and take the bed, okay? Because you will have some other babies like preterm, like babies with ARDS and so on. They are more at the top priority, okay, for this bed in the neonatal ICU. Is that clear so far, guys? Okay, so next is the same thing. They want a single most appropriate action. What is the story? Story says 2 days after delivery, a 3.6 kg female infant of diabetic mother who is in the postnatal ward developed severe jaundice requiring intense phototherapy. So what do you think? What shall we do now? If there is severe jaundice, is a severe jaundice now is indication for admission that require intense phototherapy? Yes. So now this is an indication for admission. So here you will need admission to the neonatal unit. Okay, guys, so the answer here, because of the severe jaundice. So it's according to the baby status, okay? Is the baby now have a problem with the breastfeeding? The guideline says in the neonatal part, in the neonatal care part, at the end of the guideline, just go to the echocardiography for diagnosis, right? If you suspect anything. However, this one here in this question, she had severe jaundice, okay, and require intense phototherapy. That's why admission is advised. I hope it's clear. Another case, this is an EMQ. It's a long option one, but anyway, you can find something like this in the exam. For each of the women described below, seen in the pre-pregnancy clinic, select from the option list the single most appropriate advice, single most appropriate what advice that you will give them with regards to planning or preparing the pregnancy. Pre-pregnancy counseling is very important, right? Especially in maternal medicine. So the scenario says, a 26-year-old diabetic woman attend for pre-pregnancy counseling. The hemoglobin A1C has been performed and she has been referred for diabetic retinopathy and nephropathy assessment. She returns for the follow-up to discuss these results. The hemoglobin A1C is reported as above 86, which is 8% if we speak about the percentage. She is currently on the combined oral contraceptive pills. So my question here, guys, would you advise this lady for stop her contraceptive and being pregnant, or you will advise against the pregnancy at this moment? Yes, so you will advise against the pregnancy, right? Other actions that you will take, would you please tell me? Are you going to refer her to the diabetic clinic? Yes or no? Sure, sure, okay. Are you going to give her advice regarding food, diet, exercise? Yes. Are you going to ask her to carefully monitor herself, her blood glucose level? Yes. Are you aiming to optimize the glucose control? Yes, good. Okay. So, are you going to perform hemoglobin A1C every month? Yes. Okay. So this is all considered as correct actions, right? Look to the choices, my friend. I know that the question is very clear, but I want to clear a point here in the exam technique, how to answer correctly. Okay? That, for example, measure hemoglobin A1C at the time of diagnosis. Okay, this is measured already. Commence an aspirin folic acid? No. Actually, we advise folic acid, but not aspirin. Optimize glucose control? Yes, we aim to optimize the glucose control. Why not? So C looks like a good answer. Offer a meter for self-monitoring of blood glucose. You might think, yes, why not? So D also can be correct. Monthly hemoglobin A1C, yes, it's there in the guideline. I have read that. Okay, yes. Comments on contraception and refer to nephrologist. She's already on contraception. Measure hemoglobin A1C and offer written and renal assessment. Yes, it can be correct. G. Increase frequency of self-monitoring and blah, blah, blah. Why not? So you can see here, my dear friends, that so many answers looks like it's a correct action to take. Right? Is that correct? However, there is in S, in option S, there is a clear advice against pregnancy. Right? So I'll tell you, dear friends, what is written here in the question. Single most appropriate advice that you will give them. So this is how you choose the correct answer in the exam. He didn't ask you what is the appropriate investigation, what is the appropriate follow-up plan, right? But he asked you what is the single important advice that you will give. So please be careful, because if you have a problem with the MEQ solving, so mainly the problem is that you didn't double check, okay, what is required and what is the available options. Okay, so leading word in the scenario or sentence in the scenario plus elimination method in the options. This is the key in how to solve all the MEQ correctly. Unless, of course, you don't have the information. This is something else. But most of the people have problem with the MEQ, not because lack of knowledge. They have problem because of the technique of solving. So here, guys, we are just teaching you the technique, okay? Not the information. The information you are already all good and you know it. Next question, number 11. For each of the following, what we will need, again, single most appropriate advice that you will give regard the planning of pregnancy. The story about 39-year-old diabetic woman who is not on any contraception attended the preconception clinic last week. She was assessed and the blood collected for renal assessment. Her albumin creatinine ratio has been reported to 36 milligram per millimole. Is that a significant proteinuria? Yes or no? What do you think, guys? Is that a significant proteinuria? Yes. So for a significant proteinuria, what do you remember from our yesterday discussion? We refer to the nephrologist, right? Okay. Yeah. Is it advice against pregnancy as well, or just referral to the nephrology? Okay. So I'll tell you, my dears. I will show you, my dears, okay, what's written in the guideline, because it's not about what do you think is correct, or what do you believe is correct, or what would you do if you are in the same situation or this case presented to you. Okay, no, it's not about that. It's about what is the advice in the guideline. The advice against the pregnancy in the guideline came in one situation. You know what is this one situation? What is the situation for advice against pregnancy? When the
A1C more than
hemoglobin
10.5.
A1C, yes, excellent, Dr. Mah. So when the hemoglobin A1C is 10% or more, or 86% per millimole, right? So that's mean, my dear friends, that you have to be careful in your answers, okay? It's not like, yeah, logically, I would do this, or preventing pregnancy is necessary. Who told you that preventing necessary is necessary, dear? There was an advice in the part of the renal assessment about adding what? For the woman who found to have proteinuria already? Do you remember? It was thromboprophylaxis and referral to the nephrologist, nothing else, right? And we have discussed this. We have discussed that the nephrologist, okay, the referral is mandatory, and why the increase of the albumin-creatinine ratio or the presence of significant proteinuria is adding or increasing risk factor for VTE, right? Right? Okay, so here is the part of renal assessment before pregnancy, and say offer the woman with diabetes renal assessment include a measure of albuminuria before stopping contraception. Consider referring woman with diabetes to nephrologist before stopping contraception if serum creatinine is 120 or the urinary albumin creatinine ratio is greater than, okay, than 30. So they advise the referral. They didn't say advise against pregnancy, right? So just be careful, okay, with what's written in the guideline. So the answer will be referral only, dear, okay? Okay, another MQ. The woman described below have just been diagnosed with either diabetes or GDM before booking for antenatal care. Okay, so what is required? Choose from the above option list the most appropriate advice, again, that you would recommend during their diabetes and pregnancy. Each option may be selected once, more than once, and not at all. A woman who just been diagnosed with gestational diabetes at 28 weeks of gestation, this is her first pregnancy, and thus far the pregnancy has been uncomplicated. So what's your advice now? Any advice? What is the most important advice that you will need to give? You should have something in your mind before you go to the options, or otherwise you will be lost in between what is given. Yes, excellent, Dr. Sophia. I like your answer. So you will advise hair lifestyle modification and diet control. That's good. Okay. So if it is advice regarding the diet control, okay, and maybe also exercise. So when you will see her again? When is her next appointment? 1 week, 2 weeks, 10 days? No, 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 no. Not at 32. You will leave her 4 weeks. 4 weeks, Dr. Parul, after diagnosis of GDM. She need to be seen in the Joint Diabetic Obstetric Clinic. Okay. Where there will be somebody specialist in diabetes and somebody obstetrician. She will start her journey with this clinic. Within how many weeks? 1, 4, 6, 8. What do you think? 1. Excellent, excellent. It's 1 week. Yes, well done. Okay, so if the patient initial advice was diet and exercise, and after 1 week is not working anymore, is not effective to reduce her blood sugar or control, what will be the advice? Yes, you can offer metformin. Okay, so if the woman had a very high level already of blood sugar at the time of diagnosis, what would you consider for her? Yes, it can be insulin plus also diet and exercise. Don't forget the role of diet and exercise as well. Is it clear so far?
Yes.
Okay, so well done, everyone. Thank you. Well done, Dr. Sophia. So again, EMQ, most appropriate advice required. The story is about 38, known type 1 diabetes, seen at 10 weeks of gestation at the antenatal booking. She's offered the retinal assessment and she has not had one in the last 3 months. Okay, the assessment is reported as normal. Her blood sugar level are well controlled and she's booked for detailed ultrasound scan at 20 weeks. So what you will advise? This is a woman who had retinal assessment, but it was normal, alhamdulillah. So what will be the advice now? She is now at 20 weeks. Yes, you know the answer already, and the woman will need 2 assessments. You remember yesterday when we say it's like, remember, it's like the full blood count and assessment for antibodies, right? So we would do it at booking and then again at 28 weeks. How about if the woman had retinopathy at the time at the first test? How many assessment will be done during pregnancy? 3. Yes, excellent. Okay, so this is very important EMQ for you. It's 16 to 20, Dr. Sophia, not 20 to 24. Okay, so 14, question 14. A 30-year-old gravida 3 para 0, sorry. She is type 1 diabetes and she has been on insulin pump for 4 months before pregnancy and she's now admitted for induction of labor at 38. What would be the management plan once she is in established labor? Select ones, please. She is in established labor. This question is very common exam question. Repeated recall.
Continue with insulin pump. Monitor glucose over pray.
Okay. Everybody agree with D? Just I'm waiting more answers to come. So answer is continue with insulin pump, but monitor the blood glucose when appropriate. Yes, well done. Okay. Yeah, this question, my dear friends, actually it came on one of the TUG article. I think it was 2016 TUG article. There was one TUG article about insulin pumps and pregnancy. Okay, so what was mentioned there in this TUG article, that if the woman is pregnant and she's already on a continuous insulin pump, okay, and she's now came in labor, then her pump should be left untouched, okay, if it is working normally. However, it will be also, you know, a multidisciplinary management means that there will be a diabetic team to manage this woman, but still you've been asked about the knowledge in this exam. Okay, so the blood glucose level or the blood glucose control would be maintained, right? She had the insulin pump, right? So if she's well controlled and everything is stable, okay, then ideally we don't do anything, right? But if there is any need for testing, more testing, this will be decided by the diabetic team, not by us. Okay, dear? So is that different from a woman in labor and she had diabetes but not on a pump? Or it is the same advice? What do you think? A woman who had diabetes when she is in labor and no pump, okay? What is the frequency of testing her blood glucose level? Every hour, right? We just have solved one question like this, okay? So Dr. Nas, you're asking question, and here I just wanted to clear it for you. They are not the same. A woman on a pump, continuous infusion, continuous pump, subcutaneous pump is different from a woman who is just on insulin and she came in labor. Is it clear so far? Okay, good. So 32 in her second pregnancy was induced at 40 weeks because gestational diabetes that is well controlled with metformin. She had prostaglandin gel, and 3 hours later, she had an artificial rupture of fetal membranes. Shortly after, she started contracting and progressed to full dilatation after 7 hours. She remained fully dilated for 2 hours and then started pushing. The head delivered but noticed to be receding. Okay, that means that there is turtle sign. Okay, neck sign appearance. And you were called and arrived after 2 minutes. What would be the next step to take in her management?
B.
Okay, so everybody agree? What is the first maneuver to manage? It would be great, guys, if we stay muted because of the echo, background echo. Yes, it will be Mac-Roberts maneuver, so well done. Yes. Okay, so the question next is 23 Primey, whose pregnancy was complicated by gestational diabetes. She went into spontaneous labor at 40 weeks of gestation. She started pushing, but had shoulder dystocia after delivery of the head of the baby. What factor is likely to increase the risk of brachial plexus injury in the baby? Weight or gestational age, or whether the impaction in the pubic symphysis pubis or the sacral, or what is the time it takes to deal with the dystocia, or whether it's an anterior or posterior shoulder impaction. I know it's from the guideline of shoulder dystocia, but since she is diabetic, baby weight, yes, excellent, it's a baby weight. So that's why please remember the relation between the shoulder dystocia and diabetes. Okay, this is another repeated question. The following babies were born to women who had either pre-existing diabetes or gestational diabetes. For each baby, choose from the above option list the most appropriate action that you will take in managing the baby. Each option may be selected once, more than once, or not at all. 2 days after delivery, a 3.6 female infant of a diabetic mother in the postnatal ward develops convulsions requiring NICU admission. Okay, how many days after delivery? Two. Okay, so please rule out, okay, the immediate hypoglycemia. We are afraid of the hypoglycemia when? Immediately after birth. Okay, immediately after birth, right? Okay. Hypomagnesemia and hypocalcemia both can happen, right? Later on in a baby who's born to a mother, a diabetic mother, right? Okay, so which one do you think that it's more common to happen? And it will present by convulsion mainly. Okay, so tell me why, dear. Why do you think that the hypocalcemia is the cause? Neonatal hypocalcemia can usually occur within the first 2 days of life, and most often caused by prematurity or being small for gestational age, maternal diabetes, or hyperparathyroidism as well. Okay, maternal diabetes is one of the causes, as we say. Okay, so when we have infant born to a diabetic mother, the complication can be hypocalcemia. Okay, tachycardia. Neonate can present with hypotonia, tachycardia, tachypnea, apnea, poor feeding, tetany, and or seizure, right? Okay. Okay, guys. So how about hypomagnesemia? Do you have any idea about hypomagnesemia in the newborn? The first thing that we can see with the hypomagnesemia is or the most common thing that we see with the hypomagnesemia is? What do you think? What is the clinical presentation? Convulsions, right? Okay, so one presented with, yes, it will be convulsions start early with the hypomagnesemia, right? Is that correct? Okay, so hypocalcemia will start by, do you remember? Reduced tone, hypotonia. Anything else? Anything else? Tachycardia, tachypnea, right? Anything else? Yes, so at the end, this will be the convulsions. Okay. Yes, so both of them can happen in the newborn, right? So in the exam, how to choose one of them? Okay, so which one is the most common? What do you think, Dr. Iman? If we speak about hypocalcemia, actually it's more common than hypomagnesemia. Right, guys? Okay, so now you will go to the, everybody agree? Okay, for A? Okay. So now, question 18, a 35-year-old pregnant lady with history of diabetes type 1 came to your clinic. She's now in her 35 weeks of pregnancy and the pregnancy uneventful so far. What is the next step in her management? This is a mistake in the question. When what? I think it's typing error. What's the advice, guys? What's your answer?
Delivered between 37 and 38.
Okay, so everybody agree with the same answer? Can you please, guys, read the question carefully? The question says, what is the next step in hair management, right? So what is the next step of hair management now? Is it delivery right now? Would you like to see hair once again? Yes, you will do, because hair follow-up will require another scan at 36 weeks. Right? So the frequency of a scan, okay, in the diabetes mother, this is at 32 scan, then she will have an appointment at 34 and another scan to assess the weight, the estimated weight, and to discuss actually the plan of delivery at the 36. Actually, you will find difference. You will find this table. You will find it in the explanation of questions. Okay, so at 32, offer ultrasound monitoring of the fetal growth and amniotic fluid volume. Offer nulliparous woman or routine investigation normally, scheduled for 31 weeks in routine antenatal care. At 34, no difference in care for women with diabetes. At 36, offer ultrasound monitoring of the fetal growth and amniotic fluid volume. Okay, and then provide information regarding the timing, mode, and management of birth, analgesia, and anesthesia. Okay, a change of the blood glucose lowering therapy during and after birth, care of the baby after birth, okay, breastfeeding and contraception follow-up. Yes, Dr. Sophia, it is the same. This antenatal table, it is the same for GDM and for diabetes. Okay, there is no change. And if you remember, okay, that the lady will need a gross scan at 28, 32, and 36, right? Why the answer of labor is not the correct one? Because the question was, what is the next step in hair management? This is a trick of the EMQ, that EMQs are not the same, guys. It's not like a fixed answer for every EMQ. Be careful what is the task required from you, okay? If he asks next step, then please advise next step, next appointment, next investigation, best treatment, appropriate management, advice, okay? So every time, according to the head of the question, okay, if it is different, answer must be different. Yes, answer for the question 18 is H, arrange a scan for growth and assessment of amniotic fluid after 1 week. Okay, guys? So please remember, when you solve such question, that there is a trick in this question. What is the trick that he wants? What is the next step? Question 19, 35-year-old pregnant with history of type 1 diabetes came to your clinic. She is now in her 35 weeks of pregnancy. Her last scan at 32 and her estimated fetal weight was at 50 centile with normal AFI. The pregnancy is uneventful so far. She wants to know what is the plan of delivery. So what is the answer? Please read the options and tell me what are the answers, guys. Okay, so well done. So now, did you get the difference, guys, in the question? the difference between 18 and 19? Yes, so please take care what is required in the scenario. So this will be the correct guidance for the answer. Okay, well done. So the answer is we advise delivery, induce head delivery, 37 and 38 plus 6. Timing of delivery is so important in your exam. Okay. Oh, yeah, this is the question 20. Here we're coming to the end of this quiz. So we have Mrs. XY, she's gravida, and who is 34 weeks of pregnancy. She developed GDM, currently on insulin plus metformin. Her last 2 serial scan has shown that she had SGA fetus growing on the 5th centile. And the previous scan showed a positive end-diastolic flow with normal PI. What is the best time of delivery for her? So now this is another common question in the MQ, another common idea of question that comes to you guys. Difference between plan of delivery in the cases of diabetes between GDM and diabetes. What is the condition here? This is GDM. Is it complicated or uncomplicated? Complicated or uncomplicated, guys?
Complicated.
Yes, well done. Okay, so complicated by what? Because in the guideline here, in the intrapartum care, timing and mode of delivery, it says that for the woman with gestational diabetes to give birth no later than 40 plus 6, offer elective birth by induced labor or if indicated by cesarean section to women who have not given birth by this time. Consider elective birth before 40 weeks plus 6 for a woman with gestational diabetes who have a maternal or fetal complication. Right? So, what is the appropriate time of delivery now for this case? That's the 37. Well done. Okay. The question here, Dr. Tasneem, do I need to give corticosteroids before induction of labor at 37? Especially when the lady is diabetic and she is on insulin and metformin? If the lady is going to have, why yes, why? If the lady is going to have a cesarean section, then the answer is yes for elective cesarean section, because the guideline says that consider cesarean the steroid in case of delivery by cesarean section, right? But if you have induction of labor at 37 and the lady is going to have a normal vaginal delivery, do you remember the indication of steroids in prevention of respiratory complication guideline? Do you remember this one? It said that the benefit of the steroid is up to how many weeks? It's 35, right? Plus 6 in the guideline, in the NICE guideline, okay? Then it will be at 36, okay? So the question here, Dr. Iman says, I thought it's abnormal Doppler. Okay, so if it's abnormal Doppler, when you will deliver this lady? If it is abnormal Doppler, critically abnormal Doppler.
Immediately.
In critically abnormal Doppler, right? We aim for delivery by the 32. If the patient is already 34, then deliver her. Okay, so here with the 34 delivery, do you consider or would you advise the corticosteroids, even if normal vaginal delivery at 34? Yes. The rule of steroids can benefit the baby with gestational age less than 35. Of course, this is 34. So even if normal vaginal delivery, I will consider the steroid for her, right? So please read here the small for gestational age. So first, we have decided the case is GDM, complicated baby. What type of complication? Small for gestational age. So go to the small for gestational age to take a decision in the delivery of this lady. Here, if the Doppler, the uterine artery Doppler is normal, then the follow-up will be every 14 days, fortnightly, and we will offer delivery by 37 weeks with involvement of senior clinician, right? When we will consider the steroid, if it is delivery by, here, last line in this table. Sorry, umbilical, did I say uterine? I'm sorry, Dr. Ayman. I'm sorry, everyone, guys, did I say uterine? It's a mistake. Okay, guys, so here the delivery is steroid if the delivery by cesarean section. Again, if the Doppler PI is high or the RI is high, more than 2 standard deviation, but the end diastolic velocity is present, so again, delivery will be by 37 weeks. Okay, consider steroid if delivery by cesarean section. So again, the indication of steroid comes with cesarean section. Recommend steroid if the cesarean, if you are delivering by cesarean section. Are we clear so far, guys? So when the delivery by 37 normal vaginal delivery, don't add steroid. This trick in the EMQ appeared in the last exam. Okay, so please be careful. It's tricky, and I know that people like, okay, I will give steroid. No, be careful. If you are inducing delivery by the 37, no steroid is required. If you are planning for cesarean section, then yes, steroid is required for this patient. Okay, so it's according to the mode of delivery. And be careful, because there is a new guideline about the use of the corticosteroids to prevent the respiratory complication in the newborn, and this is the RCOG guideline. In this guideline, they comment about the use of corticosteroids in diabetic mother, especially the patient who is poorly controlled. They doubt the benefit after 34. Okay, so at least so far, there is no guideline to say that in normal vaginal delivery at 37 to give steroid. There is no guideline say that. Okay, only in cesarean section. But even in the diabetes mother, this will be a discussion with the woman, the diabetic lady, about the benefit and the risk of using corticosteroids, even if it is indicated. Okay, and we will leave the decision for the mother now. Okay, to accept or not. So I don't want to confuse you. We are going to plan for revision in this guideline very soon, okay? But be careful, steroids are not indicated in induction of delivery at 37. Okay, guys? I'll be so happy actually if you remember what you remember from today's discussion is just this information. This will be enough for me, wallahi. Okay, so dear friends, take care of yourselves, okay? And if you want us to continue on sessions to solve EMQs or exam question on major topics, okay, then please give us a feedback, okay? This video is going to be uploaded on the YouTube, okay? So I will share the link with you as soon as it's ready. Please like, share, and subscribe. Yes, thank you very much, guys. Thank you.
Thank you, Dr. Rafa.